At HDI UK, we are the National Institute of Health Data Science. Our mission is to unite the UK's health data to improve and save lives. And COVID has really been a catalyst for this. So one of our priorities is to build on the gains made during COVID, to look at other pressing health crises facing the UK and global population. So we've heard from Alison, data was at the forefront of the fight against COVID-19, with the dexamethasone trial being just one example. The 2022 DHSC policy paper, Data Saves Lives, framed this as a call to action for other diseases, cancer, dementia, mental health crisis. The crisis and epidemic levels of obesity can all be tackled using similar approaches. And the policy urged investment in secure data environments, or trusted research environments, as we often call them in health data science, as a privacy-enhancing technology to enable trustworthy use of health data. So I think the priority from Health Data Research UK perspective, and many of the organisations we work across academia, the NHS and the private sector to unite data to help improve and save lives. So enabling greater public benefit from data involves moving from a one-to-one data sharing relationship to a many-to-many ecosystem. Some of my colleagues have briefly mentioned the different sources of data. If we look at how we tackle health data research at scale, we need to look at many different sources of data which are held by different organisations. Your GP is a data controller of your health records. It could be your NHS trust for hospital admission, urgent care data. If you've had a COVID test, it may be that a particular university is the data controller of the outputs of that. We then have clinical trials going on in the private sector. The Office for National Statistics holds the census data. That data will look at different population relevant factors that can be linked to health data to enable discoveries that improve lives. And there are other relevant sources of data. So, for example, data held by the Met Office looking at environmental pollution factors, unique property reference number. All of this data, bringing it together in a secure, trustworthy way is how we unlock discoveries that improve and save lives. So we're focused on a new era of health data science and health and medical care, which is based on a foundation of secure use of data across the different data sources. This article is from 2011, but looking at tackling the academic culture, since we're in an academic institution, of not sharing data, that's as important a factor as the GDPR, because it's really important that data can be shared across different populations and across different vectors. The challenge is significant, so looking at the adoption of AI and technologies across different sectors, health is not at the forefront, it's fair to say. So it's a significant challenge. And as we look at the current state of the NHS, better use of data to revolutionise a practice of healthcare is absolutely critical. And some of my colleagues have alluded to the fact that the challenges are not just legal. Lots of fantastic health data projects, UK and global, have been paused for many reasons, and quite often they're not related to data protection laws. The common law duty of confidentiality is much more commonly a problem, but we also have many other factors that cannot be accounted for by tweaking the legislation in a magic eye context.
Yeah.
Data being very siloed, different processes for accessing data, acute skills shortages for data engineering, for data scientists, enormous challenges to public trust, which are compounded by the opt-out mechanisms for use of health data. So it's very narrow to look at this in the context of just data protection laws, but there are many, many challenges in bringing together an ecosystem of health data. The law is part of the problem, and I think when it comes to data protection legislation, and particularly when you look at the public sector, there is a huge fear factor. We've really welcomed comments from the ICO around not wanting to move money around the public sector, because actually the fear of unintentional breach is felt very strongly, particularly in a sector that is hugely sensitive to public sentiment. The other areas, data minimisation can be a huge challenge in terms of research. And this plays out particularly in hypothesis-free research, where there's a desire to access large amounts of data sets to try and look for trends or correlations where it can be hard to define exactly what you're looking for at the outset. And sometimes projects fall flat at that phase because of concerns about the scope of data that's being accessed. There are huge challenges with global collaborations, particularly between the UK and the US, that fall down particularly over jurisdiction clauses and the standard contractual clauses. And I think the health data research community typically uses secure data environments or trusted research environments where the users of the data have to go through an accreditation process. The environment has to be accredited, and it's very specific curated data sets with login details for specific accredited researchers. So in that context, the additional controls over international transfers can feel excessive to the research community, but also cause things to fall flat. There is also an inconsistency of approach, and Ellis mentioned this concept of effectively anonymous. This is a term used very consistently in data science, and the Office for National Statistics uses the term functionally anonymous, which I think means largely the same thing, but looking at the whole system of controls. You have the data sitting in a secure environment with restricted access, with pseudonymization applied, and how that plays into the status of the data in the hands of the researchers, in the hands of the different organisations who've contributed the data into that, and then in the hands of what we call the host of the trusted research environment, or the organisation that's granting access. And finally, and frankly, one of the trickiest ones, I'd say, the common law duty of confidentiality and how that interplays. It is much, much, much more challenging to find a way to comply with the common law duty that is not consent than it is to find a lawful basis under GDPR. So I think there's often conflation of the two, and data protection laws get a bad rep when actually the common law duty is the much more challenging piece. During the pandemic, this was solved by the issuing of COPI notices. And critically, as Alice mentioned, COPI notice mandate data sharing, they don't permit it. Other legislation like the Digital Economy Act, which is what the ONS relies on, permit data sharing, whereas COPI notice is mandated. That's really critical. But the COPI notices have all expired. Research that was previously using large linked data sets for COVID has either stopped or needed a different legal basis under the common law duty. And critically, some of the large data resources that were developed for COVID and could be used under those COPI notices can't now be used for research into asthma, diabetes, and the other really critical health problems facing the country. There we go. I love this article, The Road to Hell is Paved with Good Intentions, the experience of applying for national data for linkage and suggestions for improvement, published in the BMJ. The BMJ doesn't publish that much about data protection, data governance, but this is really interesting, and I think it highlights part of the problem. This was health data researchers trying to access different sources of data and link them together from different data controllers. And it took them 2.5 years to do this, because every data controller has their own process, and it's usually an application form which can be several hundred pages, and you need to do that process across everybody who holds the data, and they're all slightly different, so you have to sort of huge amounts of duplication and limited consistency. And one of the problems here, for anyone who's done a PhD or postgraduate research, your funding normally doesn't let you hang around for 2.5 years whilst you're trying to access data. So it's an enormous problem, and it's not that anyone is struggling to comply with data protection laws. It's more many versions of good which don't converge. So part of the work we're trying to do at HDI UK is bring some coherence and standardisation across those processes to try to agree across the main controllers of health data one version of good. These are just some examples of one of the factors I mentioned around international research collaboration. So there have been real examples of international collaborations, research collaborations between the UK and the US, which have fallen down. And in both these cases, it was over questions about jurisdiction clauses in the context of data that's being held securely. And finally, just to bring this back to an image that Alison shared around the national data opt-out, the legal question is part of the problem, but public trust is a huge challenge, very fragile. A wise person once said to me, change moves at the speed of trust and not the speed of legislation, which I think is very true here. We can't legislate our way around the public trusting the use of data, and particularly not in circumstances where they have opt-outs. So this spike we saw in opt-outs, this was in 2021 when the GP data for planning and research was implemented, and lots of people were getting WhatsApp messages from their auntie saying, quick, go and opt out or your data is going to be shared. This was a project to put GP data into a secure data environment. I've been watching the metrics since, and the announcement about Palantir being brought in to run the federated data platform for the NHS caused a smaller but still noticeable spike. So really important to keep all of this in context, and any reform that does take place must be done with proper public involvement, public engagement, ethical input, and meaningful communications with the public about what's happening with their data. Otherwise, people will vote with their feet, and that means that the data that the vital research is being built on isn't representative. We know that women have a greater tendency to opt out than men. Certain ethnic populations have a greater tendency to opt out. And so actually, if you're not represented in the data cannot give us the best possible NHS for our country. So important to balance both the permissive or even mandatory legal regime with ensuring that the public has confidence in how their data is being used.